I use the Eclipse membrane for just about all of the possible corneal and conjunctival findings that you could bill for. I would say that if you looked at we have a log sheet, and so I document every time that I apply a membrane. It actually has to be documented because it's a biological tissue anyway. But I would say by and large, your corneal findings, right? So not your run of the day, diffuse punctate keratitis. That's not going to get paid for. But your clinical findings that actually have some type of complaint, reduced vision, pain, sensitivity. Neurotrophic keratitis is a big one, but you've got to make sure that you have documentation, that you have done some type of corneal swab test, something that's going to assess cranial nerve 5, and document it so that you actually do have the substantial findings to back up a neurotrophic keratitis diagnosis code. I definitely do a whole lot of first line treatments where I'm going to have antibiotics for corneal ulcers, peripheral corneal ulcers, flutenules, marginal ulcers, marginal degenerations, central corneal ulcer just the other day. I'm going to have the conjunctive therapy where I'm having my amniotic membrane with a contact lens bandage patch, and then I do my antibiotic slash a steroid combination if it needs. Those are some of my main cases. I would say here recently, it's summertime. My logbook shows that I've had 4 different cases of corneal abrasions from a couple baseball players, a couple people that are working in the yard. So my go-to treatment, corneal abrasion, you got to have the injury date, and you actually have to have the clinical finding for the corneal abrasion. And usually you can actually do next day billing or zero billing if you understand what that means. And then I have long-term patients that I treat. I see them on a monthly basis for a Cancer Society treatment center where I know that they're going to have long-term effects from their medications. I would say that all of those are of normal clinical findings on a weekly basis. The other large modality that I use it for is I treat and manage a lot of dry eye patients. And one of the findings that we're tackling, everybody's jumping on board with the eyelid meibomian gland management, and they're not really addressing the loose conjunctival tissue that's not allowing the proper absorption and securing of the mucin layer of the tears. So conjunctival chalasis treatment, where we're actually heating the conjunctival tissue with plasma treatment and then applying a membrane. That's one that a lot of eye specialists, a lot of eye doctors don't even have a lot of knowledge in, and it's kind of becoming more the forefront. We're seeing more and more lectures on it. So I would say that anything from in the H16, H15, H11 codes that I would say I am using it on a weekly basis. The Eclipse, I prefer the 5 millimeter Eclipse for smaller, more peripheral issues. And if it's more of a central issue or a conjunctival issue that I want a large area of migration of the properties of the membrane to properly secure and absorb in, I'll use the 8 millimeter membrane.